Bowel obstruction occurs when intestinal contents cannot pass through the GI tract. The obstruction may occur in the small intestines or colon and can be partial or complete, simple or strangulated. When obstruction occurs, intestinal contents, fluid, and gas accumulate above the intestinal obstruction. The abdominal distension of retention of fluid reduces absorption of fluids and stimulates more gastric secretion. With increase in distension, pressure within the intestinal lumen increases, causing a decrease in venous and arterial capillary pressure. This causes edema, congestion, necrosis, and eventual rupture or perforation of the intestinal wall, which results into peritonitis. There are two types of bowel obstructions: mechanical, which there is a physical obstruction of the intestinal lumen, and non-mechanical, which occurs when reduced or absent peristalsis due to altered neuromuscular transmission of the parasympathetic innervation to the bowel. Some common causes of bowel obstructions are surgical adhesions, also hernia, and strictures from Crohn's disease. Some clinical manifestations of bowel obstruction is abdominal cramp and pain, constipation, nausea, vomiting, and colicky abdominal pain, which usually is the first manifestation of an obstruction, as well as abdominal distension. Some diagnostic testing for small bowel obstruction is imaging through CT scans, and abdominal x-rays can identify the presence and location of an obstruction. They will also guide decisions about surgery. Sigmoidoscopy or colonoscopy may provide direct visualization of an obstruction in the colon. Blood tests will include a CBC, which is a complete blood count, and blood chemistries. Elevated white blood count may indicate strangulation or perforation. Elevated hematocrit may reflect hemoconcentration. Decreased hemoglobin and decreased hematocrit levels may indicate bleeding from neoplasms or strangulations with necrosis. Frequently monitor serum electrolytes above and creatinine to assess the degree of dehydration. Watch for metabolic alkalosis through ABGs for vomiting. Surgery may involve removing obstructed section of bowel and anastomosis, remaining healthy bowel. Corticosteroids and antiemetics may be used to keep patient from vomiting and decrease inflammation of the bowel. Less severe obstructions may be treated with adequate hydration, the use of laxatives to add bulk to stool, or increase peristalsis. Enemas may be used alone or in conjunction with manual fecal extraction. Some complications include intestinal strangulation, which is when blood flow is inadequate, bowel tissue will become ischemic, then necrotic, which is dead, and the bowel may perforate, which is a hole forming in the GI tract. If the bowel becomes so distended that the blood flow does stop, edema, cyanosis, and gangrene of the bowel segment occurs, leading to intestinal strangulation or infarction. Hypovolemic shock or severe dehydration of the patient is also a potential complication. When managing a patient with a bowel obstruction, it is important to monitor for signs of hypovolemia or bowel strangulation. Monitor the patient's I&O, record onset, frequency, color, odor, and amount of stool and or vomit. Note for any abdominal tenderness or rigidity. Monitor for activeness of bowel sounds and NG tube care if necessary.